is when there's less data regarding a condition, you may think that the burden of disease skews more toward rural areas. Just based off of the data, it's actually the opposite.
Hello and welcome. This is Rethinking Rural Health Financing, and you are listening to the podcast that is asking the question too many people forget. What about rural health? I am your host, Chinasa Imo, and together we are uncovering these stories, the challenges and innovations that are reshaping healthcare in overlooked communities. In this series, we ask questions around how money moves, who gets funding, who gets served, and who gets excluded. From policy to practice, we explore what healthcare financing should look like for everyone. It's an obvious assumption that when we talk about the drivers of rural health, healthcare inequity, everybody tends to towards, oh, there's not enough clinics and there's no health workers. But we sometimes do not recognize that there are other real gaps, such as, are there really health data visibility that can help us measure what is funded? Because what is measured is usually what policymakers would fund, and what is funded is what they will prioritize. But we see that without data, without adequate data, how much can rural health issues get into the national framework? And this is what my guest and I, Cameron, is going to explore today. We're going to ask questions that include, if rural health is not fully visible in the data that guides policy, innovation, and investment decision, how then can it truly be prioritized, and what can be done to turn around these scenarios so that rural health can be measured and not be ignored? So, Cameron, I wanted to flip the conversation. I've seen your profile. It's quite intimidating, award-winning health policy and outcome researcher. You know, you work as a senior staff member at the Lancet IHME Global Burden of Diseases Initiative, and you've co-authored a lot of articles and academic papers, including the Lancet 2025 US Presidential Briefing book. But I actually want you to tell us a little bit more about yourself and what you're currently doing right now that is exciting.
Yes, of course. And thank you for having me. And thank you for this warm introduction. Thank you for creating this space. So my background is in health policy, outcomes research, and really population health data. That's where I kind of built my profile academically. As you said, I work with the Lancet and the Global Burden of Disease Initiative, where we kind of analyze how health data informs national budgets, policy priorities, investment decisions. We create that health data, we put it out there, and we analyze it across decades, across the whole world, across different countries, across different world economic zones. So we do a lot of global work, and then we also bring it back to the United States. So how does policy inform outcomes here in terms of how does data inform policy, which informs outcomes here? So we do a lot of work on national data sets within the Global Burden of Disease Initiative right here in the United States as well. So we're a very national and global phenomenon. And across all of this work that we do, one thing really becomes clear. It's that communities that are not well measured are often not well served. And, rural populations are a prime example of this gap. And I'm excited to talk about how data visibility shapes financing decisions and what it would take to make rural health impossible to overlook. Now, just briefly, one thing I wanted to mention here is when there's less data regarding a condition, you may think that the burden of disease skews more toward rural areas. Just based off of the data, it's actually the opposite. So what we find consistently is that rural health populations have much lower incidences and prevalences and DALYs and however you'd like to measure it. That's disability adjusted life years. because it's not measured at all. And so there's nowhere to measure it. And so there's nowhere to get treated. And so it looks like the disease burden is much lower. So we actually have in our DISMOD calculations adjustments to make to adjust based on how many healthcare institutions are in a rural area per population, adjust it upwards in the calculations. But even then, we predict that we are underestimating the burden of disease in rural populations severely. And that's why I really wanted to hop on this podcast. Thank you for, giving a platform to people.
You're welcome. And I think that your introduction set us up really good in the conversation that we want to have right now, because what is not measured is not known. At least from a policy perspective, as a policy student at I graduated from the Harris School of Public Policy, and our mantra is data drawn to science. It's so funny. We make joke about that, but that is true, because without abundant data, you cannot make a case for something. And that sets us up for the first question that I want to ask you, because it's obvious we can say that from policy perspective, and people within the policy spectrum will understand what we're talking about. But for a general audience who do not easily connect what data visibility and ability to measure things would look like, and how that informs what is signaled or signposted to policymakers and what is not. So when you say that, what do you actually mean? And in explaining all of this, can you add the fact that whatever is missing in the national data or in the global data can actually impact how rural health, population health is adjudicated within health financing?
Okay, that is a very large question to unpack here.
Yes.
I
Yes.
appreciate it. So what I'm getting at here is perhaps, maybe what does it mean for rural health to be visible, measurable, impossible to ignore, and what's missing in current data systems? Is that what you're asking here?
Yes.
Okay.
Yes, exactly.
Yeah. So when I say rural health needs to be specifically visible and measurable here, I mean that it needs to exist distinctly in the data sets that drive decisions. Right now, a lot of rural health is statistically diluted, and rural populations are often grouped into larger regional or national even averages that smooth over the specific risks and any access barriers or disease burdens that aren't measured at all. And I'll give examples. So the United States obviously broken down into statewide burdens in the global burden of disease data set. And so is, for instance, Iran, and a lot of just random countries dispersed. But if you take somewhere like, I don't know, Ethiopia, or I'm really pulling these out of my head. I don't know which ones are specifically not versus is, but there are many that aren't broken down into regional or broken down into subnational contexts. And so let's say Kazakhstan or Ethiopia. Obviously, there are central hubs, cities that have so much access, and a lot of people live there, and so the national averages just wipe out any context into rural populations. And when those data drive decisions, and the UN looks at the reports coming out of the Lancet and says, "Look, this country, we need to rank the countries by their burdens, and certain countries have extremes of wealth and poverty, extremes of access and inaccess, and they rank low because they're, the elites in that country have so much power, or the city centers have so much healthcare that everyone else is drowned out." Well, that actually misallocates resources and funding. And so their needs never rise to the level that triggers policy attention or funding shifts, specifically at the global level. And what I mean by that is maybe USAID investments, which are already dwindling, but already in a resource-strapped environment. USAID, World World Bank funding, funding from nonprofits like Bloomberg Philanthropies or Bill and Melinda Gates Foundation, they dry up for different countries that don't show that their needs are visible. And that comes from the infrastructure in place to be able to take that data. And what's missing is not just more data, but the right structure of data. So we lack consistent rural identifiers, or like obviously the subnational resolution, but also the longitudinal tracking that captures how health outcomes evolve over time in specifically rural settings. So without all of those pieces, rural problems and populations appear smaller than they actually are. There's also data management practices that unintentionally obscure the rural realities. So, for instance, the thresholds for reporting are often designed around urban population sizes. So, small rural communities fall below those thresholds and disappear entirely from analysis. And in other cases, surveys and other registries rely on digital access points that rural residents are just less likely to use, or even institutional access points. So to your last point, this is about both indicators and collection methods. So the indicators we under track, like travel time to care, provider scarcity, delayed diagnosis, maybe financial toxicity, when those indicators exist, the way we collect data often fails to reach those rural populations consistently or equitably. And that's what I mean by what's missing in the visibility of rural health.
Thank you for your response. I think that if I am to try and recap what you said, what you imply here is that there are specific indicators that either we are not yet tracking or they are set up in ways that are making it impossible to capture the actual data that is needed to make rural health visible. And I want to agree with you. I am from Nigeria. When you were mentioning countries, I'm like, I hope he would mention Nigeria. And I own a nonprofit. Now, I come from the eastern part of Nigeria. And when we hear a lot of development aid coming to Nigeria overwhelmingly, and by the way, it's just 2% of the overall GDP, right? However, these aids go to mostly the northern part of Nigeria, not because they have overwhelming problem. I mean, that's not to diminish the issues happening there with insecurities, Boko Haram and the rest of them, and what that causes to rural communities. But it just ignores, seems like there's just a sheer ignorance of other regions of the country, like the eastern part, where we do we have similar insecurity with the IPOB and kidnapping and the rest of them, plus rural health issues that are overwhelming. But because the national data are skewed in the ways they are collected and documented, it seems like those areas don't have problem. And you cannot really make a strong case when you don't have solid data too. So thank you for saying that, at least for describing that very clearly to us. We will go for a very quick break, and when we come back, we'll continue this conversation.
If you're enjoying this conversation, don't forget to subscribe to What About Rural Health on all podcast streaming platforms. We are on Spotify, Amazon Music, Apple Podcasts, Listen Now, and so on. And yes, we are on YouTube too. Your support means a lot to us. Please leave a comment, share, and most importantly, give us a review. It helps others discover this important conversation.
All right. Back to the episode. You are listening to What About Rural Health with Chinasa Imo. So I want to dive in, Cameron, and talk about financing itself. How much does this poor data visibility affect where funding goes? I know you talked a little bit about it, but be more specific in terms of government budget, donor investment, and innovative funding mechanisms that we are seeing coming up now, especially with global fatigue in global health funding.
Yeah, absolutely. This is a very important question. And this gets to the heart of this podcast in general, and the series about financing. So data visibility is one of the strongest predictors of where money flows. Government budgets, donor allocations, and those private investments rely heavily on any quantified burden that you can have. And if a problem doesn't show clearly in the data, it rarely shows up on the budget line. And, in practice, the poor rural data visibility leads to systematic underinvestment. So rural areas may have higher disease severity or worse outcomes, but if those outcomes aren't measured at sufficient resolution, then they appear less urgent, as you mentioned, than urban health challenges that are well documented. And this affects everything from hospital funding to grant eligibility criteria. And when this can go into a tailspin, because when there's less infrastructure, there's less reporting, and the divide between rural and urban infrastructure grows, and thus the reporting grows, and the cycle continues. So, donors and the innovation funders behave similarly. So they're looking for the metrics, benchmarks, measurable impact, and if this data is sparse, it becomes really harder to justify investment, especially when even when the need is obvious on the ground. So it's really it's a challenge to make these cases for these environments that really no one knows about and no one's reporting. And this actively shapes financial priorities.
Thank you for that response. I want to add a rider to my earlier question, because now we've seen a lot of transformation in innovations in healthcare. There's a whole lot of conversation around the use of AI, generative AI, intuitive AI, and all of that, digital health, and even new delivery models that folks are now seeking out to see how to pivot healthcare, in ways that bring in new models. But the conversation still remains the same when it comes to rural health. They are the last to benefit. But I want to ask you, in terms of incorporating this innovative health data transformation into rural health community data management system, what kind of resources that we need to improve that? Or, I can ask this question from two ways. What is not being done yet? Where are the gaps? But what should we begin to do?
So really, this comes down to, why does the innovation gap persist for rural communities, and what does this mean for them? I think innovation ecosystems, especially, by companies backed by firms like Andreessen Horowitz or Sequoia Capital, are under pressure to demonstrate, really rapid growth, high user volume, near-term returns. And rural health systems may serve tens of thousands rather than millions. And they don't fit those expectations, even when their needs are acute and the potential impact is actually higher. And so, beyond that, though, there's also the dominant innovation ecosystem in healthcare is structurally aligned around urban environments and, academic medical centers. So, organizations like the National Institutes of Health, Centers for Medicare and Medicaid Services, and, other major venture capital firms concentrate their funding in those environments where the patient volume, data density, and the specialized labor already exist. And that creates a reinforcing loop where innovation chases the infrastructure rather than addressing where the gaps are greatest. I'll give an example. The proton therapy. I went to the University of Pennsylvania. I passed by Penn Medicine all the time, and they would have proton therapy there. And they also do at Johns Hopkins and other major academic centers. Very few of them, but they're there. And same for radiation oncology. A lot of the infrastructure there doesn't exist at all in rural areas. And so I've actually, about the proton therapy, there are literally not proton therapy machines in most of America, in most of rural America. Unless you live on the East Coast and you're close to one, it could be very expensive to, have your family fly out to a hospital if they care about you enough to take time off work and go all the way out to a hospital in the middle of nowhere that you haven't been to. And so you live in Kentucky, you're going to Philadelphia, for instance, for your cancer treatment. And that can rack up bills very, very fast for families who live in Kentucky. And otherwise, it's really hard to get access like that. And so that's one primary driver, innovation chasing infrastructure, and another one is the data bias that we discussed. So a lot of digital health and AI tools are trained on data sets from large Western academic institutions in urban environments, like Massachusetts General Hospital or Penn Medicine or Columbia or what have you, and those data sets reflect well-resourced urban populations. And, I'm not only speaking about the United States, we can talk about other places as well, but generally just urban, well-resourced patient populations with consistent follow-up, subspecialty access, advanced diagnostics. But when those same tools move to rural hospitals, like critical access hospitals, performance degrades. And, the predictive risk models or anything that they try to implement miss the broader social geographical factors. And thus, clinical decision support may assume staffing levels that don't exist at all. And this is where, and my mentor, Dr. Allison Martin, Alistair Martin, he was at Massachusetts General Hospital. He just became health commissioner of New York City. He has worked a lot on broadband internet access as a healthcare issue in rural communities, because telehealth platforms presume broadband visibility or reliability that many rural counties still lack. And so it's not just access to the infrastructure, it's access to the healthcare, even telehealth. And so, finally, the policy and reimbursement structures reinforce the gap. So the programs administered by CMS often pilot new payment models in large health systems that have the administrative capacity to manage reporting, risk adjustment, and compliance. And, the rural populations that this isn't tested on as much frequently lack the staff to even participate in these pilots, which means innovation is tested without any rural input and then scaled nationally. And by the time rural organizations are expected to adopt the model, it's already misaligned with their operational reality. And then finally, the success metrics themselves are misaligned. So innovation is typically measured by the speed of deployment, the number of users, or the short-term cost savings. And, rural health success looks very different than urban health success. It's measured in access preserved, services retained locally, that you don't have to refer out to a larger facility, workforce stability, turnover, system resilience over time, especially in the COVID pandemic, when a lot of pediatric units just had to shut down across the nation because they didn't make enough money to stay solvent when all the kids stayed home because they were too afraid to go to the hospital and catch COVID. So organizations like the Rural Health Association, the National Rural Health Association, the Rural Health Information Hub, they've documented these differences for years, but these are never or rarely incorporated into the mainstream innovation frameworks. So this all this constellation of complex issues just makes rural communities inherently harder to serve. But not just that, it's because the structure of innovation is designed, funded, and evaluated without them at the table.
I like the last word that you just used to conclude this. And one thing that struck me in the conversation when you discussed about people traveling from their community to a nearby place where there is services, and I'm just looking at the transfer of data repository from that, say from Pennsylvania, to the neighboring place where they get care, because that is then where their data situates, and you know what that means for planning and continuous funding. It means more population resides in this place without understanding. I mean, we theoretically understand that there is movement of people to seek services, but in terms of what that data would be used for planning, and funding prioritization, it already neglects this other population that is, being referred to this place. But I think at this point, I want to turn it over to our listener to reflect a little bit. Whether you're a policymaker, researcher, or practitioner, how visible are rural population in the data that you rely on to make decisions? Or how are you incorporating rural health data into your health study design, please drop us a comment in the comment section below. While you are reflecting upon this, let us take a quick break, and when we come back, Cameron and I will continue the conversation.
Do you want to help drive rural health forward? We're looking for passionate volunteers to support our work, from research to storytelling to business outreaches. If you believe every community deserves care, join us. Visit the link in our bio or show notes to sign up.
Welcome back. You are listening to What About Rural Health with Chena Saimo. So, Cameron, I'm going to turn this back to you. Say we begin to pay more attention to the data. Say we live in a world now where we are really paying attention to data, not just as information gathering tool, but now using it as drivers of rural health financing decision. Are there specific models, whether novel or existing ones that you have seen that is making tangible differences, models where better data is helping to elevate rural health issues or funding priorities, or where through improved government engagement, you are seeing changes happen? Because we need to signpost those models for people to realize, oh, it's not just about talking about the problem. There is some solution, or there could be already existing solution in smaller scale that we can scale up.
Yes. So, I really appreciate you, taking the effort to call these models, try to find what models are working right now. What I will say is these models, just generally, you have to look for models designed for low density, geographic spread, limited institutional capacity, because the objective is not to scale down urban systems, but to build data infrastructure that works in sparse environments that have variable care. And so one better model is actually called place-based data systems. And so county service level area data are more useful than national averages for rural planning. And I'll give you two organizations. One is the Rural Health Information Hub, and the other is the University of Wisconsin Population Health Institute. And they both show how integrating health outcomes with workforce, transportation, socioeconomic data produces good, actionable insight for any rural decision makers. And I've done a lot of work in this, actually. One of my projects recently was on orthopedic burden and then how that relates to economics. So, like in terms of employment rate and all these other things, what is the burden of different conditions that can be debilitating for people, and how does that relate to workforce workforce participation, economics, income, et cetera, et cetera. And a second model after the place-based data systems that I'd like to discuss is the distributed data collection. So in rural settings, care delivery extends beyond hospitals to mobile clinics and community health workers, EMS, public health agencies. But the programs supported by the Health Resources and Services Administration increasingly emphasize capturing the data from these non-traditional settings to reflect how care actually happens. Then also, another issue that you mentioned regarding people transplanting themselves to other areas is the issue of electronic health record interoperability. So we need lightweight, affordable systems, national standards promoted by the Office of the National Coordinator for Health Information Technology. I've written editorials for this regarding this. They're very effective when paired with the technical assistance for small hospitals and clinics. Without that support, the interoperability aspect of EHRs and systems remains inaccessible for rural providers because there's still some seed funding needed to create the infrastructure shifts to hook them up with larger data sets and larger systems. And it's still really hard to do a bona fide, strong national study without having access to every patient from everywhere. Right now, data is fragmented, and rural health hospitals are getting, the short end of that stick because they're not being represented in national studies. Finally, Yeah.
Okay, go ahead, continue.
Yeah, the longitudinal monitoring. I just wanted to mention how, a lot of these workforce shortages, chronic disease progression that occurs and smolders in these rural populations unfold over years. And so we need all payer claims databases, remote monitoring, and that's better than one-time snapshots.
Thank you. I just want to add a follow-up question. Are they, from your expert standpoint, are they systematic or systemic barriers that we need to address for any of this model to effectively work across context or demography?
Yeah. One major barrier is capacity. Obviously, rural health systems don't have the resources to collect, analyze, report high quality data without external support. A lot of them operate on very, very thin margins. And so one small shock, like a pandemic, which is a huge shock, can send a lot of them in the red for many years before they become in the green. And that can lead to closure of essential services like pediatrics wards in favor of conversion to orthopedics and, specialty specialty places that just bring more resources to that hospital that's struggling. So that can undermine primary care and other very basic services that a hospital should provide to its community. Another barrier is the standardization. So data systems are often fragmented across any regions, and it becomes very difficult, as I mentioned before, to compare findings in a way that influences national policy. And finally, there's really, to be quite frank, a political barrier. Data that exposes inequities can
That
be
is
uncomfortable.
obvious.
Yeah. And data that exposes inequities can be uncomfortable and often censored. Scaling these models requires commitment from policymakers to act on what the data reveals and not just collect it or fire people who try to act based on those data.
Thank you so much, Cameron. I wanted to say maybe one or two things that I'll take away, but I think I'll stick with one. I think one obvious thing that you have spoken about here is the fact that we at least we need to disabuse ourselves from national aggregates. That is one thing that I hear you, and begin to look at model that's not just scaling things to meet, but also looking at what is applicable at the local level that would be able to strengthen data collection and management system. That being said, as we wrap up, Cameron, I wanted to ask you one final question, and this is me being always coming, ready to change the world or have the mindset that, okay, my guest can change the world, or this episode can trigger some level of change, and coming with that mindset. If you could change one thing about how rural health is measured globally, what would you advise a data manager to stop doing?
Yeah. Stop treating rural health like background noise. It's not. A lot of the rural data is flattened into national averages, discarded because the numbers are small and, people think it doesn't matter as much. And, in rural health systems, small numbers are the system. That is the entire thing. And so a single hospital, single workforce pipeline, single road often determines whether care exists at all. And when rural indicators disappear into those aggregates, the early warning signals are lost, and the closures look sudden, and the crises appear unexpected. In reality, the data was there. People just ignored it. And rural health data should be treated like a stress test. And when we treat it that way, and not like a footnote, we see fragility sooner, act earlier, and invest before any collapse becomes inevitable.
Thank you so much for this conversation, Cameron. I really appreciate the insight you've shared here today, especially around how data visibility shape rural health financing and policy priority. It's been a thoughtful and important discussion, and I'm glad we could have you on this podcast.
thank you very much for giving people like me a platform and for advancing the priorities of rural health. I think it's the most important thing you can do in this world.
Thank you. Thank you so much. To everyone listening, thank you for joining us on today's episode of What About Rural Health? If today's episode moved you, challenged you, or made you think a little differently, please follow, subscribe, and leave us a review on your favorite podcast platform. And as always, let's keep asking the question, what about rural health? Until next time, I am still your host, Chinasa Imo. Bye for now.